Thank you so much for joining us. I'm Celina Yong. I'm an associate editor at JACC, and I have the great pleasure of talking today with Professor Chao Gao, who is a leading investigator for the REC-CAGEFREE I trial. Thank you so much for joining us. Firstly, I want to say that we're so thrilled to publish these results in JACC this week, the 3-year results of the trial alongside your presentation as a late breaker at TCT. I want to commend you and all of the investigators on completing now 3 years of follow-up for this large-scale investigator-initiated randomized trial looking at drug-coated balloons versus drug-eluting stents for the treatment of de novo coronary lesions across the spectrum of vessel sizes. And in particular, I have to applaud you for the manuscript that really goes beyond just an update of what's happening at 3 years, but you really have driven into details about temporal patterns over time, antiplatelet therapy to inform how we think about bleeding risk and subgroup analyses. So I'm really excited to get a chance to talk with you. And I'm hoping maybe you can just start with giving us a review of the trial design and what you found at a high level with this 3-year update.
Thanks a lot, Professor Yang. So in a CAGEFREE I trial, previously, the paper, the primary endpoint at 2 years was presented in the Lancet, and now we have the 3-year result published in JACC. So I think for start, someone will say, is it an additional 1-year report, or is there something new? I think definitely I would say there's quite some interesting findings at 3 years. So the CAGEFREE I trial was designed to test whether DCB with the rescue stenting was inferior, if it is non-inferior to DES in terms of DOCE, which is cardiac death, target vessel MI, and clinical and physiologically indicated target lesion revascularization. Previously, at 2 years, we found non-inferiority was not reached, and DCB was in fact inferior compared with DES. And now at 3 years, we found the result was consistent. Still, DCB was inferior to DES. But here's something new. In the landmark analysis, we found the gap between DES and DCB was getting gradually smaller. So that is the P4 trend with time was a 0.023, which is positive. That's one of the main findings we found. Another quite interesting is that, you know, that the DOCE primary endpoint has 3 components: cardiovascular death, target vessel MI, and clinical and physiologically indicated target lesion revasc. And the most important, the 2 component death and MI was numerically similar between the 2 groups. The reason why DCB was inferior was mainly driven by the more revasc. And if we look closer, we divided the revasc into urgent and elective. All the differences was caused by the elective revascularization rather than the urgent revasc. So different interpretation might be interesting because target vessel MI were similar, urgent revasc were similar. So technically speaking, DCB was inferior to DES. But if we consider revasc as a reversible event rather than irreversible injuries such as death or MI, so because DOCE was previously used predominantly to compare one stent versus another, but here's a different scenario, DCB versus DES. A revasc in DES might mean something, stent layer after layers, but for revasc in DCB, it's not a irreversible injury. It's just like a delayed bailout stenting if there's no important consequences such as MI. It's just like a delayed or bailout stent. So people have, we think people should to interpret the result carefully, because on one hand, the primary endpoint was obviously still inferior, but on the other hand, the DOCE should be interpreted like there's no irreversible injury for DCB. So I think that's the main finding. And we have to say, so far it's just like the details into data. We will present the 5-year result, death plus MI, and all-cause death at 10 years to see what's the outcome, the prognosis between the two devices in the long run.
Thank you, Professor Gao. So your results show that the excess risk of DCBs is concentrated in the first year, but the absolute rate of events is still greater at each time point with DCBs compared to drug-eluting stents. So what is your interpretation of the relative incremental risk of both DCBs and drug-eluting stents over time?
We have to say that the DCB at 1 to 2 years, 2 to 3 years is still numerically higher compared with DES. But the gap is just getting smaller and smaller. And the gap, like we discussed earlier, is still mainly caused by revasc, not the target vessel MI or the cardiac death.
That's right. You did a beautiful win ratio analysis that I think really drives home that point, showing us that it's the repeat procedures, and among them really elective repeat procedures, that's driving this outcome. One question I had for you is that the trial design was an open label trial design, and I wonder how much do you think that may influence the findings with respect to elective repeat procedures?
We definitely wanted to do the trial in double-blinded fashion, but that's not feasible because every operator will easily find out which group the patient was by a simple floral. So this trial was conducted in an open label design. We found that the operator will have a tendency to look at the patient in a DCB arm more closer, and if the patient was complaining about a symptom, the patient were more likely to have a repeat angio or the CCTA. So in order to prevent the observational bias, we deliberately used the endpoint not as just a straightforward target lesion revasc. We added a term called clinical and physiologically indicated, which means the patient should have a symptom and a QFR or FFR below 0.8. If the patient had a revasc when a QFR or FFR above 0.8, it was not adjudicated as an event. But if the patient had a positive test and that was counted as a CPI-TOR. But still, I think the open label will cause more repeat angio and more CTCTA, which could have a bias toward the more revascularization in a DCB arm, which I think this issue could be overcome with the longer follow-up at 5 years, or to see all-cause mortality and target vessel MI. But at 3 years, I think we still use the endpoint, the primary endpoint at 2 years, which is DOCE, and still we observe more revasc in the DCB arm, which could have been consequences of the open label design. But in other words, the target vessel MI were numerically similar. So I think more revasc could have been preventing the potential more target vessel MI in patient in a DCB arm. I think revasc could also be an issue related to that.
Thank you. Those are important points. Another issue I wanted to ask you about was the presumed advantage of DCBs in terms of bleeding. So you were able to explore antiplatelet medication use over time. And I'm curious if you think that the bleeding advantage is real for DCBs, or is this simply reflecting different medication patterns? What do you think?
Honestly, I think it's real, based on 2 points. First, because during the designing phase of CAGEFREE I, there's no consensus document, there's no randomized trials showing how patient with DCB should be prescribed with antiplatelet therapy. So although there's in a consensus paper saying that patient treated with DCB could have a less intense antiplatelet therapy, no one knows how we should do that. So we asked the operator to do their best for the individualized patient, how the patient could be treated. And eventually we observed that in patient with DCB, less than between DES, there's a 10% less patient treated with DAPT between 6 months to 1 year. And eventually we found the p-value between the two arms is 0.53, if I remember, 56, 0.056 between the major bleeding in terms of BARC3 bleeding events. And I think because patient treated with DCB could have a less intense DAPT, and I think that could be a potential advantage for the DCB. And this is point one. And the second point, we were also curious to know how the patient should be treated with DAPT after DCB. So we conducted another trial, which has been published in BMJ this year. We call it REC-CAGEFREE II. And we found that, in brief, 1 month DAPT followed by 5 months of ticagrelor monotherapy, and then 6 months of aspirin monotherapy was non-inferior to standard 12-month DAPT with aspirin plus ticagrelor in terms of NACE, need adverse event. So I think taken together, patient treated with DCB could have a less intense antiplatelet therapy used, and which should be counted as a potential benefit for DCB. And because this is something new, we just know, and I think for further trials comparing DCB versus ES, the advantage of less bleeding should also be taken account while designing trials, because those, as we mentioned earlier, is the conventional endpoint we use to compare one DS, one stent versus another. It's not designed to compare between balloons versus stent. If the balloon has a potential benefit in reducing bleeding, this should be also taken into account to explore the overall benefit for patient with DCB, rather than just comparing between two devices.
That is a very good point. So to follow up on this idea that certainly bleeding risk is an important patient group, high bleeding risk is an important patient group for these drug-coated balloons, you did a number of subgroup analyses, also looking at a number of different factors, including non-small vessel disease. Could you share your thoughts on where you think, if anywhere, DCB should be considered first beyond just high bleeding risk, potentially beyond just small vessel disease?
I was just talking to Professor Scheller yesterday on an email regarding the data between basket small 2-3 years and our data. And he also agreed with me. The data between basket small 2 and the small vessel subgroup in CAGEFREE I was so much in concordant. I think in patient with small vessel disease, defined as a vessel diameter below 3.0, DCB have a numerically similar event rate compared with DES. And now we are preparing a meta-analysis, pulling all the data together with in collaboration with Professor Davide Capodanno to see whether in border range DCB would have a numerically similar rate compared with DES. I think DCB in small vessel disease is definitely a very interesting and potential indication. But in the large vessels, we're more conservative based on our data. I think DS should remain for the preferred device in patients with large vessel disease.
Thank you. I also want to ask you about the device-specific implications, because as we understand, there's no class effect for DCBs, and here in the United States, we don't have access to the SWI DCB that you use. Could you share just a little bit about the features of that DCB, maybe contrast it with sirolimus-based balloons or even other paclitaxel balloons?
I think this is also a very important part to interpret our data. We also have sequence please, which is a B. Brown's paclitaxel-coated balloon in China. But in order to do a trial, the CAGEFREE I used SWI and DCB. The SWI DCB was designed quite similar to the sequence please B. Brown DCB. But like you said, which we totally agree, there's no class effect for DCB. And so in order to know that whether the REC-CAGEFREE I was, the result was still valid in the real world data, we have conducted a study to compare DCB versus DES in the real world setting. And all the patients treated with DCB used B. Brown sequence please compared with DES. 2,500 B. Brown DCB was compared with 5,000 patients treated with DES. And the paper has been accepted in BMC Medicine. And we found that the result was very similar to the randomized cohort we have in REC-CAGEFREE I, which is dose is still higher in patients treated with DCB, and also mainly driven by the more revasc. So I think the result of CAGEFREE I was robust, but it should be interpreted like this way. This trial was aimed to compare DCB versus DS, and we have the patient randomized after lesion preparation. So those patients if the patient was not successfully pre-dilated, the patient were not randomized, but into a different nested cohort treated all with DES. The patient were successfully pre-dilated and then randomized 1-to-1 to DCB versus DES. If the operator felt that the patient have a tendency of acute recoil or a large dissection or reduce like a limiting flow dissection, the patient will be treated with a rescue stenting, which is 9.6 in the REC-CAGEFREE I. And so the study should not be interpreted like an overall strategy. DCB, intended DCB, if the patient is not successful, will be combined with a DES to compare with DES. If we randomize before, and we randomize the patient in the first place, there will be mixed up like 30% of DCB plus 70% of 30% of DES plus 70% of DCB compared with all 100% DES, which we think it may not be fully comparable between the arm because it will be biased toward reaching non-inferiority in the DCB arm. We wanted to know how DCB would perform alone. So that's our aim, and we designed the trial like to randomize after lesion preparation. So I think it should be also taken into account while interpreting our results.
Thank you. Can I ask you more about that actually? So if you randomize patients after their lesion has been prepared, is it possible that the way that we would prepare a lesion prior to drug-eluting stenting would be different than how we would do it before DCB? Maybe we'd be more aggressive if we knew that we were going to be using a DCB afterwards. And do you think that point could have contributed at all to the bailout stent rate?
Indeed, if we wanted to stent a patient, we typically will not be so aggressive in doing lesion preparation. But in the REC-CAGEFREE I, all patients were required to be eligible to do a DCB. So all patients had a relatively aggressive lesion preparation in order to could be randomized to DCB. And the criteria is resolute stenosis below 30%. There's no large dissection type DEF, and also TIMI flow is at 3. So all the patient before randomization is already ready to do the DCB. I think, and also to ensure the patient is ready for do a DCB, there's a standby eligibility committee to review all the cases in order to make sure all the patients were ready. So eventually the bailout rate is 9.6, and we have tried to see whether this number is low or high compared with previous studies. And we put all the data together of previous study, and we found out this number is just right in the middle of all previous studies, which we think this number is okay. It's not high, it's not low, but if we're looking at all small vessels disease only, the bailout rate is ranging from 5 to 7% after the DCB.
Thank you so much. Professor Gao, to wrap us up, I wonder if you could just summarize where you see the role of DCBs now, given all the information that we have, including results from your trial.
Thank you. So based on our data, I think DCB in SVD will be a possible indication for large vessel disease. DCB alone might not work, but still a hybrid strategy covering DCB plus DES might work, but still we need more data regarding this issue.
Thank you so much again for having this chat with us today, and congratulations to you and your entire team of investigators. We're thrilled at JACC to be publishing your work this week.
Thank you for having me.